Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm your editor and host, Dr. Adam Stryker. Today, I'm joined by my colleague, Dr. Stephen Butz, who happens to be president of SAMBA, the Society for Ambulatory Anesthesia, along with a couple other colleagues, Drs. Victor Davila and Thomas Durick. Today, we're going to discuss some common perioperative myths and misconceptions that have percolated through time. Maybe a potpourri of topics. We thought this would be an interesting way to tackle a few items as it relates to specifically ambulatory anesthesia and try something a little different today. So I'm looking forward to this conversation, and I just want to thank all of our guests for joining us today. I'd like to start by asking each of you to introduce yourself to our listeners and tell us a little bit about your practice and your role with SAMBA.
Sure. Thanks for having us, Adam. My name's Stephen Butz. I am the immediate past president of SAMBA. I actually just relinquished my president role in May. But I am a pediatric anesthesiologist in Milwaukee. I run the Children's Wisconsin Ambulatory Surgery Center. And like I said, I am just recently coming off being president with SAMBA.
My name is Victor Davila. I am an anesthesiologist at Ohio State University Medical Center. I do, obviously, ambulatory anesthesia, and I'm the treasurer for the Society for Ambulatory Anesthesia, but also have a significant amount of my time spent as an intensivist in the critical care unit. And it's a pleasure to be here.
And I'm Tom Durick. I'm an anesthesiologist along with Victor at Ohio State. I'm relatively new to academics. I spent 30 years in private practice before coming to academics. Most of the time of the last 2 decades, I spent exclusively in ambulatory surgery centers, and I am currently our anesthesia clinical operations director for Outpatient Care New Albany, which is one of two and the first surgery center that Ohio State built and now runs. And I'm currently the chairman of SAMBA's Performance Measures Committee, which with Dr. Davila's help, we're morphing into more than just a performance measures committee, but we're adding a lot more value measurement, cost measurement, and analysis for anesthesiologists.
Excellent. Well, thanks to all of you for joining us. Why don't we start off the conversation with Dr. Butz. And Dr. Butz, we're going to talk a little bit about some common perioperative myths today, but let's have you give just a little bit of an overview to our listeners on why that's important. What kind of price is paid when healthcare professionals, but particularly anesthesiologists, are not only exposed to lore, but perhaps succumb to it? And what kind of concerns should we be aware of when we're not getting perhaps the most accurate, up-to-date information?
That's a great question, just because I feel like anesthesiologists a lot of times spend a lot of their practice fairly solo. We don't have a lot of interaction with our colleagues. And when we do, it's a quick, hey, how do I take care of this problem? And so you just get a lot of word of mouth education. Certainly with today's access to online things, it's out there. But a lot of times when you're getting that quick curbside consult, it gives a big opportunity to kind of perpetuate these myths that either people picked up in their training or something that they may have glanced or overheard. And these things kind of just perpetuate themselves, and right or wrong, it happens a lot. Sometimes it's a great way to transmit information, but sometimes you get the wrong information in your hands and you might not necessarily recognize it. So this was something that came up in our annual meeting, and we actually did a whole panel on it. And it was one of those ones I think went over really well. Everybody in the audience, I think, heard something familiar that either they were right or wrong about. And I think it was a great learning moment for a lot of people in the audience.
When I think back to things that I learned in training that ultimately changed over time, I think myths or misconceptions we used to carry with us were based on our teaching that just hadn't gotten up to date. But one new variable in today's society that wasn't present when any of us were training, or at least wasn't as prevalent, the idea of social media or a plethora of online information. You probably have a really good perspective on how that plays into the misconception, whereas before it might have just, for lack of a better term, maybe been a passive misunderstanding, whereas now, how much do those avenues weigh in on almost more of an active misunderstanding that we have to contend with?
Well, I don't think any one of us has not run into a patient who's, been to visit Dr. Google. I mean, there's a lot of times that patients bring things up, like I'll have someone in prep say, well, my kid's got red hair, so you're going to give, more pain medicines, right? Or they're going to wake up crazy. So there's a lot of stuff that's out there that's kind of right, or at least you can figure out where they've heard or what's going on with it. But a lot of times I find that some of these either urban legends or these kind of myths that go on that are presented to you are presented in a setting where you're on the spot to answer right away. And I don't know that everybody is either 100% prepared, or if it's just easier to say, oh yeah, I agree, and let's move on because I'm running late and let's hurry up with this case and it doesn't really matter. But it is harder to take that step back and either really look at what the latest literature is on a topic, or to really get a consult with someone who would be knowledgeable either in your department or in your group. But sometimes I feel like we're having to do this on the fly, and I think it perpetuates it a little more, especially when, someone's had a similar procedure, like patients who come in for things sequentially, and they're like, well, the last anesthesiologist told me this. So then you're kind of like caught over that barrel of, you don't want to throw your colleague under the bus, but it might not necessarily be right. So you kind of have to mold the way you're saying it. So there's a lot of finessing with this, and it really helps to come from a strong point of view of knowing the actual facts and really what this is on, and being able to dismiss people or reassure them or whatever it takes to kind of say, no, this is safe, this is why I'm doing it, and this is what the latest or the most recent teachings say.
Well, let's tackle a few myths. The first one I want to talk about is hypercarbia versus hypocarbia. Dr. Davila, you've worked on this topic, and why don't you go ahead and maybe introduce this a little bit to our audience? Not obviously what hypocarbia is, but why this is an issue, and what new findings or new information we should probably be a little more abreast of.
Sure. I wish I was going to say new information. It's more information that has kind of been rediscovered multiple times. It gets discovered about once every decade or two since the beginning of when people started doing anesthetics. The basic idea is that hypercarbia is something that should be avoided. And when I was a resident, I remember vaguely getting instructions, to keep somebody's, for example, end-tidal CO2 between, 32 and 35 or 30 to 35, with the idea that you're compensating for an end-tidal CO2. So end-tidal CO2 to the PaO2. And, to kind of keep them under that 40. So you didn't allow the patient to get hypercarbic. And like I said, every couple of decades or two, we kind of discover that that's a bad idea. It's been discovered a couple of different ways, but in a nutshell, whenever you make somebody alkalemic or give them a respiratory alkalosis, that's not something that, a lot of the tissues and a lot of the things in the human body are really designed to kind of compensate for. And so what ends up happening is that you have some cardiovascular changes, including, decreased inotropy, decreased perfusion. It also becomes harder for the blood to kind of release that oxygen, which everybody's familiar with. So it holds on to the oxygen better. The cells kind of get to wave at the oxygen as it goes by. And then you end up with just a general decrease in the oxygen delivery to many tissues. That in and of itself is probably not a great thing, but where you see a lot of these effects is actually in the central nervous system, and specifically the brain, which is obviously a pretty oxygen hungry organ. And so what you end up seeing is that you have this kind of cognitive dysfunction that's pretty common, and it's been pretty well described in several different contexts, related to making patients alkalemic. In other words, breathing them down. And so it's probably a better idea to keep somebody slightly hypercarbic with an end-tidal CO2 in the high 30s, maybe 40 or so, and kind of allow for the patient to be slightly acidemic, because it's hard to know exactly what it's going to be unless you have a blood gas, but it's better to be slightly acidemic than slightly alkalemic. And, you can actually see there've been, for example, there was this one study that I really liked where they took people that like to go mountaineering. They took these people that can climb a big mountain. So they're pretty healthy at baseline. And they had them climb this big mountain. And there's two basic types of people. As the oxygen levels decrease, there are people that just kind of breathe normally. And there's people that tend to hyperventilate as a way of kind of compensating for this kind of lack of oxygen. And what they found was that this hyperventilation actually led to measurable cognitive decline for several days afterwards in this completely healthy population. And so you can imagine in some patients, for example, especially some of our older patients, where you have this idea that people keep kicking around, this kind of grandma has never been the same ever since she went to surgery. And there's increasing evidence to say that a lot of this has to do with just changes in oxygen delivery to the brain. So in a nutshell, that's the basic idea, that you probably should make your patients more hypercarbic than you typically do, or than many people typically do. And that will actually lead to other changes in your ventilatory mechanics, or allows for other changes in your ventilatory mechanics that are probably good for the patient also, but that are slightly different from the topic of hyper versus hypocarbia.
Comment just briefly about the ambulatory setting versus a more acute inpatient setting.
So with this particular issue, in the ambulatory setting, you'll see, for example, just patients having, a little bit less delirium when they wake up, probably. Kind of makes it a little bit easier to get them out of the PACU if they have a slightly easier time. There's not a lot of hard data related to decreased PACU length of stay and those kinds of issues. But I will say that as these things are improved, you have, just generally speaking, better outcomes with these patients. When we think of somebody having a difficult time getting perfusion to their head, we think of this as an issue where if they don't have a stroke, they're okay. And I would argue that, just kind of generalized, slightly decreased oxygen delivery is not great for getting patients up and out and reactive and just kind of with it when they get out of surgery. And at least anecdotally, it definitely makes a difference in patients that I've taken care of.
Well, I do have some more myths that I want to discuss with all of you, including one concept that I think has got to be at the top of the list of the most misunderstood concept in anesthesiology. So please stay with us through a short patient safety break.
Hi, this is Dr. Jeff Green with the ASA Patient Safety Editorial Board. Communication gaps during patient handoffs in the perioperative setting increase the risk of patient harm. While electronic tools can improve communication and patient safety during handoffs, low-tech strategies can go a long way toward ensuring continuity of care and accurate information exchange. These include standardized checklists and templates, as well as patient safety communication techniques such as read back, repeat back, and other closed-loop approaches. Formalized structured templates ensure that key information is communicated to all personnel involved in care transitions, such as for OR to PACU or OR to ICU transfers. For shift changes in the OR, a less formal and more portable 3x5 note card with key safety information can be handed to the clinician assuming care of the patient. With both approaches, face-to-face communication between providers is essential for a safe handoff. There is no one-size-fits-all strategy to safe handoffs, but adopting a standardized process may improve patient outcomes.
For more patient safety content, visit asahq.org/patient safety.
Well, we're back discussing myths, misconceptions with our distinguished panel of ambulatory anesthesiologists and SAMBA members. Dr. Durick, I want to turn to you to talk about MAC, because I think MAC is got to be one of the most misunderstood concepts widely out there. If you don't mind, let's talk a little bit about the concept, maybe a brief overview of what MAC truly is, a little bit about what your work entails on this topic, and what we should know about MAC, especially as it pertains to ambulatory surgery centers.
Thank you, Adam. As I mentioned, I spent over 2 decades in private practice running surgery centers besides just working in them. So I was able to see the implications of billing something as a MAC versus a general, where it didn't affect the facility billing, but it definitely affects the anesthesia billing. So first and foremost, the best anesthetic, people think MAC is better or it's not as good in an ambulatory surgery center. The best anesthetic is the safest anesthetic for your patient in your hands for that patient at that time. So what I'm trying to do is, besides have people think safety first, is to realize that there are just constant threats to our ability to practice, and most importantly, get paid for that practice. Dr. Harder put that out there in his Monday morning outreach. It was about 8 weeks ago. I believe it was on April 15th. We was talking about how some of the insurance companies are no longer going to pay for the physical status modifiers. And we all know that the higher the ASA physical status on a patient, the more risk it is for the patient and for us to care for that patient. So there were several states where Blue Cross Blue Shield is opting out. They're going to follow Medicare's lead on that. Aetna says they're following through. So one of my big initiatives, and it's been this way for 30 plus years, is to make sure we get paid for the work we do. I don't want to see the anesthesiologist taking a medical legal risk and not getting reimbursed for that risk they take. So the definition of MAC varies depending on who you're looking at. The ASA basically defines MAC. It says it's a specific anesthesia service performed by a qualified anesthesia provider for a diagnostic or therapeutic procedure. And it goes on to say it's not just the actual anesthetic itself. You still have to do the pre-anesthetic evaluation, optimize care, do post-op, but you also always have to prepare for whatever degree of anesthesia and sedation. You are always prepared for a conversion to a general anesthetic. All of the risks still go through there. And MAC, they say, is varying levels of sedation, awareness, analgesia, and anxiolysis in there. When you look at Medicare's definition of MAC, it says it's the intraoperative monitoring by a physician or a qualified anesthesia practitioner of monitoring the patient's vital signs, and again, in anticipation for the need for an administration of a general anesthetic and managing the adverse reactions to the surgical procedure. What I find interesting is their definition still says giving PO medications like atropine, Demerol, or Valium, and I don't think that that is very common in this time frame. And then if you look at the insurance company's definition of MAC, it basically says it's a continuation of care. It's a continuum of degrees of sedation to where you are trying to keep a patient from either having recollection, having knowledge, or responding to painful stimuli throughout the surgical procedure. But again, has to be done by a qualified physician or under the medical direction of a physician or an anesthesia care provider. So to get those wonky definitions out of the way, the biggest threat to us is we have to remember how we get paid when we're doing nerve blocks. When I started at Ohio State, there was a myth. It was a genuine myth that if I did a block in the operating room, I could not get paid for it. And I still have talked to colleagues over the last 30 years who still believe that, and that is inherently untrue. When you look at the Medicare's National Correct Coding Initiative, which they put out every year, which tells you exactly how you bill for things, it says that the block can be done before, during, or after the anesthetic. And I think the one thing that people forget, and the one thing that we are trying to push in the facilities where I work, is you should have in the note by the surgeon, in the operative note, that they are requesting assistance with post-op pain management. The insurance companies pay the surgeon and the surgical team as part of their global coverage to manage the post-op pain. We think of post-op pain in the first 24, maybe 48, 72 hours if we're putting a catheter in, but you have to get the surgeon's assistance. So more and more insurance companies will deny your block if the surgeon's note does not say, I requested assistance with this post-op pain management. And the last thing I want to make sure people understand that if you're doing an epidural or you're doing a nerve block, the type of anesthesia has to be either a general, and when you're doing a nerve block, it can be a spinal, an epidural, or a general, but that anesthetic should not be dependent on whether your nerve block or your epidural work. So if you are doing a nerve block and you're billing for a MAC, most of the time the insurance company is going to deny you the nerve block because that is your primary anesthetic. And the last thing is, I've seen people say, well, then I'll just say I'm doing a general with a natural airway, which is great, which most of the times we're doing. But Medicare has the 7 components for how to get paid for medical direction. And number 3 says that you personally participate in the most demanding aspects, including, if applicable, induction and emergence. We really don't have an induction in MAC. It's a continuum, but a general anesthetic has an induction. If you're using an EMR, there is an actual point where you must click induction. And to be able to bill for that, to be able to bill for the general, the anesthesiologist must be present during that induction. So you can't have it both ways. You can't say, I'm going to do a general with a natural airway, but I don't need to go in the room because it's really a MAC. If you're following the letter of the law, if you're going to pass your audits when CMS, Joint Commission, AAAC, Quad ASF, whoever comes through there and does your chart reviews, they need to see that you were present. You're checking that box that you were present during inductions to make sure that you can get paid for your block.
Okay, so what should the average anesthesiologist out there practicing in an ambulatory surgery center, what would be the takeaway here? What should they do when they listen to this podcast? What would be the one thing you'd suggest to them?
The biggest thing that I would suggest is 2 things. Is one, that they learn that you can do the block before or during the case. So that is a myth. If you do the block after the patient's asleep, you've gotten consent, you're doing an ultrasound guided regional anesthetic, you can still get paid for that block. But again, if you are billing it as a MAC or a regional anesthetic with a MAC, you will not get paid for that block. You can still bill for it, but you will not get paid for that block. It is considered your primary method of anesthetic. So the biggest takeaway is that the anesthetic is not dependent upon your block. If I'm doing an interscaling block for a shoulder reconstruction, I'm doing a general anesthetic with an LMA, and I'm doing a block for post-on pain management. I make sure my surgeon has that inherently in their note. Every shoulder we do, we're going to do a block. It's in their note. I've asked anesthesia for assistance for post-op pain management. So number one, I've checked that box. And two is that the adequacy of the anesthetic is not required that my block has to work. Now, we hope that it always works. And if we're using ultrasound guidance, it should always work, but it's not dependent upon that. That is basically your take-home message, is that if I'm doing an AV fistula and I'm doing it under a block and the block doesn't work, well, then that's my primary anesthetic. So as long as your block is not your primary anesthetic and you can still bill for a general with the induction and you are present, that's a take-home message. Just make sure you're billing correctly and that you're billing to the letter of the correct coding initiatives for Medicare.
Should we be correcting individuals, not even necessarily anesthesiologists or anesthetists, about the term of MAC? Because it is used a lot, I think, as a surrogate for IV sedation or mild sedation. And I feel like it's a term that it's just made it into the lexicon of a lot of perioperative personnel. Ignoring the ramifications of that, does that contribute to a lot of the misunderstanding, or just misunderstanding of anesthesiologists?
I really think it does, and that's well said, because again, all of the different governing bodies, including the ASA, they do state that MAC is a continuum. A MAC for a 10-minute cataract is different than a MAC for an hour and a half difficult tortuous colon or an upper endoscopy. It is that continuum. What does not change is that an anesthesia provider has to be present during that anesthetic, and that we are continuously vigilant and ready and prepared to do a general anesthetic and to treat any of those physiologic aberrations that might happen because of the sedation, because of the procedure, because of the surgery. So MAC is that continuum. MAC for a cataract can go south quickly if they're pulling on the eye and all of a sudden that patient Brady's down, or heaven forbid has no pulse. Suddenly we have to be there to quickly interact with that. The conscious sedation or moderate sedation, the guidelines by the ASA, should be followed by every place where sedation is given. That if you have to do an airway maneuver, you have now gone beyond the definition of moderate sedation. Moderate sedation states that the patient is able to respond to verbal stimuli, not painful stimuli, but verbal stimuli, whether it's a thumbs up, give me an okay sign, say, yes, I'm doing okay. But they also do not need any assistance in maintaining a patent airway. So if you're doing a colonoscopy and there's no anesthesia personnel in the room, and all of a sudden they're doing a jaw lift because the patient's desaturating, they've gone beyond moderate sedation. They're now either into a MAC or a general anesthetic with or without a natural airway. So part of what we as anesthesiologists have to do, having the oversight anywhere sedation is giving in a building where we work, is make sure we're educating our non-anesthesia providers, our nurses and our proceduralists, what is safe sedation and where they should draw the line.
Well, there's a couple other misconceptions that I'd like to talk about with Dr. Butz. One is involving preoperative evaluations and one's involving allergic reactions. And so, Dr. Butz, do you mind talking a little bit about the myth regarding preoperative evaluations to start?
Absolutely. And actually, I'm kind of stepping in for one of our SAMBA members, Ken Cummings. What he was talking about was the recent CMS change about ambulatory surgery not needing a 30-day H&P. That's always been kind of like that golden rule going forward with surgery that, where's the 30-day H&P? Can't do the case without the H&P. So really what research has shown is that in a healthy ambulatory patient, that the H&P made no difference to outcomes. And different literature actually showed that doing routine perioperative testing actually increases morbidity and mortality to patients by basically flagging false positives that get chased down the rabbit hole. So a lot of these things, what we've always held as always holy going forward is that we had to have these, was actually completely wrong. And if you are at an ambulatory surgery center, you don't need a 30-day H&P anymore, according to the Centers of Medicare and Medicaid Services. Now, of course, your own policies might overrule that, but it's something definitely worth looking into and something that is absolutely true.
That is certainly good information to have. Over the years, I've been involved with so many cases that have been delayed, if not canceled, because of that particular issue. And so it's at the very least, it's nice to see that it's being looked at in a more definitive manner on what the real benefits or downsides are of something like that.
Right. And absolutely, it's only for ambulatory surgery. It's not for even outpatients done in the hospital setting. So that's where the setting really matters in this case.
Gotcha. Well, I know you want to talk about allergic reactions, or I should say allergies in medicine more specifically.
Yes, out of almost everything in this panel, this is the one that really rang the truest to me for the conundrums I come through on a daily basis. And this is something that was presented by Jamie Hyman out of Yale. And one of the things that you always hear about, or you see like a patient who has either an egg allergy, and then you get flagged in your EMR that you can't give propofol. So what's the deal with that? Part of this is taking a step back to really look at what an allergy is. You know, our immune system is a great thing that protects us, but what the immune system is best about identifying is either big proteins or really long chain carbohydrates. So small molecules really are invisible to it to the most part. So in keeping that in mind going forward, it'll help make a little bit of this clear. So looking at propofol, the thing that people always talk about, like, oh, well, there's lecithin in it. It's got to be eggs. So yes, propofol is an alkyl phenol that is the active drug. And what it's in is that emulsion that's made up of soybean oil, purified egg lecithin, and glycerol. So you're like, okay, so what's the deal? The problem is egg allergy is to the protein that's in the egg white, not the lecithin that's contained within the egg yolk. So again, having an egg allergy for a large, like 99% of the people, isn't from what is in propofol. The other thing that you see is soybean. So again, the allergy in soybean is going to be the protein that's in the soybean. Remember what I said, this is an emulsion made of soybean oil. So what they've done is they've ultra refined the oil, so there's no proteins in it. And again, oils usually aren't something that our immune system sees. So again, a soybean allergy would not cross over with a propofol allergy. And then the last thing that you see is every now and then you'll see like a peanut allergy to say, oh, do we need to avoid propofol just because they're allergic to everything kind of stuff? And again, the peanut allergens are part of the prolamin superfamily, which is what most of where the allergies for that come in, and none of those are in propofol. So again, if you've got an egg, a soybean, or a peanut allergy, you're safe with propofol. And that was even backed up in a study that looked at patients who had an allergy under anesthesia and they didn't know what it was from. So in investigating 153 of these patients, they only found that 4 of them were diagnosed with a propofol allergy. And out of the 4 that actually had an allergy to propofol, none had an egg, soy, or peanut allergy. And then they did the reverse of this, and they looked at patients who had egg, soy, and peanut allergies, and they looked to see if they had any reaction to getting propofol. And in 171 anesthetics, none of those nearly 100 patients who had the food allergies had any reaction to propofol. So it kind of bears out in that study of not a huge one, but looking at it pretty closely. One of the other things you see, this is usually when you're prepping the case, like, oh, patient has an iodine allergy. We can't use betadine. So a patient with an iodine allergy can't get a betadine prep. So what do you do with that? And again, if you really think about it, an iodine allergy, you can't really be allergic to the element of iodine. It's too small to get recognized, and it's something that is an essential element to live. So you can't be allergic to that any more than you can be allergic to iron, say, because iron's in your hemoglobin. The other one that you see is the seafood allergy. You know, is that something that's going to cross-react with betadine because of the iodine in it? And really, the things that cause seafood allergies are the proteins that are in the seafoods. And those are things like parvalbumin, collagen, tropomyosin, enolase. So all these things are not things that are going to be found in our preps. The other thing that's probably bigger than all of them is penicillin allergies. You know, you always see, particularly in pediatrics, oh, patient has an amoxicillin allergy. What do we use? Can we give cefazolin, or do we have to move over to clindamycin? So the thing to remember with this is that out of all the penicillin allergies, trying to find an IgE-mediated allergy to beta-lactams is incredibly rare that there's an allergy to the beta-lactam core. What it's related to is the R1 group that's on here. And penicillin and cefazolin have different R groups. So there is zero cross-reactivity to that. And that by patients limiting that, it basically denies them of the superior cover of cefazolin than clindamycin for their preoperative antibiotics when that's indicated. And that kind of brings up another bad problem when you get into EMRs, is when someone gets a penicillin allergy into their EMR, it is literally like an act of God to get that removed. One of the things that I've learned recently is that in our hospital, the pharmacy department will actually work to remove this from patients. But it takes a lot to do because there are so many databases that this perpetuates. It's not just like in your local EMR, but it goes to the local pharmacies and it goes to doctors' offices and it's all over the place. To really be able to stamp down and get that allergy removed is really hard. And even the more difficult part with this is that the things that go into a true allergic reaction is going to be that IgE mediated response to allergen. Things like just getting a rash or breaking out aren't allergies. That most of those are just side effects of the drug, which frequently happens with, amoxicillin, with morphine. It's like they're not allergies, they're just histamine releases or something that's a different mediated allergy. So having that conversation with the patient, not to dismiss them, but to actually try and educate them and say, actually, amoxicillin, this is a side effect from it, particularly the longer you take it or the more often you take it, but it's not a true allergy. And so being able to give the patient the right drug is something that can be hard to do. And I think a lot of people just kind of like throw up their arms because there's so many roadblocks in the way. But the right thing is to give the right drug to the right patient for the right purpose.
Well stated. You brought up a number of issues, but one thing I do want to specifically ask is an example pertaining to propofol. Individuals, even including myself a number of years ago, that were reticent to give propofol to someone that had the egg allergy, not necessarily because of the science, but because of the drug insert that specifically said it is a contraindication. And as practitioners, we're nervous about giving a drug and having some untoward issue and then having it looked back upon as it could have been contributory, even if you know that that probably wasn't the causative agent of any kind of problem. And I feel like in recent years, the amount of investigative work done by all of our colleagues and putting it in the literature has pretty much nullified that concern. So my first question is, A, do you think that's true? That from a medical legal perspective, that the amount of evidence out there pretty much has made that concern a moot point? And number two, is that the kind of work that as clinicians we are left to have to do to combat misinformation or outdated information included in a drug insert so as to, as you stated, give the right drug to the right patient?
That again, that's so multi-layered, but I'm glad you brought it up because actually the insert for propofol differs by country. So where you might see, propofol in Europe versus the United States or like different countries in Europe, it may or may not have that egg warning to it. The egg warning came from our FDA making it go in there. So that's where it gets into the more difficult parts of getting to the true source of where this comes from and how you do it. I think very forcefully, we've vindicated egg allergies from being an issue with propofol use in our literature. And so trying to spread that and trying to get that out is very important. You'll see that a lot with some black box warnings that really change the way we use medications, like what came up with codeine. But you really have to know what's in there, where it came from, and basically who's in control of this and what the plus minuses are either way.
Yeah, it's such important work because you do not want to deprive someone from any kind of agent that you think is going to benefit them in any way simply because of technicalities, if you will, a technicality not related to the science.
Correct.
Well, this has been a great discussion, and I do want to take the opportunity to ask all of you a little bit about the SAMBA organization. We've been trying to focus a few of our podcast episodes this year on subspecialty societies, and I'm sure everybody listening, or at least most, are familiar with SAMBA as the organization, but maybe not necessarily the work specifically. And maybe there's other things you'd like our listeners to know about the organization. So why don't each one of you talk a little bit about the organization, or just give your thoughts or things that you'd like our audience to know? Let's start with Dr. Davila.
Sure. So SAMBA has been doing a lot of work, and it has for years, to try to make sure that we are a very responsive organization to our membership. And we, I think, do an excellent job as an organization of kind of providing a one-stop shop for ambulatory anesthesiologists, providing information related to regional anesthetics, the kind of ERAS technologies that are coming, going, and evolving. And it's a small enough organization that you still get to meet and speak to all the people that are, doing all the actual research. You get to meet some of the leaders in the field and walk around at our conference and really get a good opportunity to kind of discuss things. And I feel like our members are extraordinarily knowledgeable and always inform the way that our organization kind of faces the world and tries to put out guidelines and information that really help move the subspecialty of ambulatory anesthesiology forward. It's truly an organization that I've found extraordinarily helpful in my practice, and I'm very grateful to.
Dr. Durick, how about you?
As a newer member to SAMBA, again, I spent 30 years in private practice, and most of the time I was solo. So for almost 20 of those years, I was truly not part of a group. So when your meeting funds are limited, I didn't focus on some of those bigger meetings. And talk about misconceptions or myths. I always felt, SAMBA didn't pertain to me. It's a bunch of academic people just talking about research. Absolutely the opposite. What impressed me the most the last 3 or 4 years now that I've been a part of SAMBA, it's the passion. The people at these meetings are absolutely passionate about improving the quality of care, improving patient outcomes, and improving the ability for us as providers to do a better job. So it was that passion. And just like Dr. Davila said, when you're walking around, people will come up to you and they will ask you questions, especially if you present it. And with my niche, with the financial side of it, I got a lot of questions about that. It's the chance to interact with people who share your passion, but then want to take that message home to wherever they work. Small group, large academic practice, huge private practice, it does not matter. It's that passion, those people that want to make everything better, safer, more efficient, not just for our patients, but for each other. That's what impresses me the most about SAMBA.
And Dr. Butz, let's leave the last word with you.
I have to say, hearing what, Tom and Vic said just really makes me feel so good, because I've been involved with this organization for a long time, for almost 20 years now. And that's exactly what I like to hear from it. We have a saying that everybody does ambulatory surgery, but not everybody does ambulatory anesthesia. I think that we try and tell people how to do things well. It's something that when you come from our meetings, I've been involved with organizing our meetings for the last few years, and it's always been my goal to actually give people useful knowledge to come home from. I think that when you see something, you see the people who are on the forefront of making it work and are really solving your day-to-day problems. And this goes for, again, not just academics, but like Tom was saying, like the private practitioners who might not have access to this stuff otherwise, or might just think that, I don't care what, all the academics think. We're not writing papers on, whatever the solubility of the newest anesthetic agent is. But this is actually really a nuts and bolts kind of thing of how do you do your job? How do you do it well? How do you avoid the pitfalls in the road as they come up? And really, how do I become a better provider?
Well said, all of you. This has been a great conversation. I certainly hope we get the opportunity to do this again, because we just scratched the surface on so many topics. But Dr. Davila, Dr. Durick, Dr. Butz, thank you so much for joining us today and sharing not only your insights and expertise, but your time.
Thank you very much.
Yeah, thank you so much for having us.
Yeah, we really appreciate the opportunity.
Wonderful. Well, for those of you that are listening, hopefully you enjoyed today's podcast. If you want to learn more about SAMBA, please check out the website at sambahq.org. Check out our catalog of previous episodes and tell a colleague about the podcast if you find it interesting. And don't hesitate to leave a review on your favorite podcast platform, and certainly join us again next time. Take care.
Stay ahead of the latest practice and quality advice with ASA anesthesia standards and guidelines, freely available to keep you up to date. Browse now at asahq.org/standards-and-guidelines. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.